my topic is amniotic membrane transplant for refractory corneal ulcers. It's not moving. All right. So, as we all know, amniotic membrane is basically it is retrieved from the placenta. It is the innermost layer of the placenta when we procure it at the time of elective cesarean section. It is 20 to 50 micron thick, and basically it has epithelium and basement membrane and stroma, and the rest chorion that's we discard. So we are interested in uh, the innermost part of it. So amniotic membrane, it is basically used as an adjunctive procedure in various surgical specialties and also in translational medicine to cultivate the stem cells. Can be used as a permanent therapy as well as temporizing measure until the inflammation has subsided and a definitive reconstructive procedure can be performed. So routinely what we use, we have various options. You can either use fresh amniotic membrane, cryopreserved, or dry. Every one of these have their own advantages and disadvantages. Fresh is when you basically procure at the same setting, fresh from the delivery room, cesarean section. It is thought to have a better biological function, but the concern is transmission of blood-borne infection. So it's not very popular among the cornea surgeons, but where we don't have the other option, it serves well. Dry, it is dehydrated and it is stored at room temperature. It comes in like this box, no commercial interest, has a long shelf life, 2 to 5 years. So it's very handy when in emergency settings or when we do not have other wet or fresh amniotic membrane. It is less expensive, longer shelf life, and easy storage, but the problem, it's very brittle, difficult to suture, and may have lower retention, and also because most of these stromal fibers or the substance is not there, so it doesn't integrate really well with the uh, underlying tissues. So these are the just a couple of pictures how this dry amniotic membrane look like, and basically these marks here, they are basically for orientation in the basement side up or down. And so for BET, it is prepared in the eye banks under sterile condition and stored in Dulbaco media, and it retains the innate character. It rules out the blood-borne infection because we usually use it after 6 months or so. It keeps the extracellular matrix intact and therefore promotes tissue regeneration. Disadvantage is very few eye banks process it and not easily available, and also storage is an issue. It has to be kept in a refrigerator. So this is how it is prepared. Then there are other commercially available wet membranes like Procera, but these are very expensive and not easily available in India. Indications, they have vast spectrum of indications in cornea and ocular surface diseases, like in Stevens-Johnson syndrome after pterygium surgery, chemical or thermal injuries, ocular surface tumor after excision to cover the bare sclera, fornix and eyelid margin reconstruction, socket construction, and another very popular is the slat and comet. There basically it serves as a platform over which the epithelium grows. So amniotic membrane basically in settings where we don't have any other tissue available, and it is something which even comprehensive ophthalmologists can inculcate in or incorporate in their practice without bothering about the organ laws and other stuffs. Uh, Amniotic membrane has also found use in retinal disorders, especially for the closing of the macular holes, refractory or recalcitrant. In cornea, uses are chemical burns, bullous keratopathy, acute Stevens-Johnson syndrome, after superficial keratectomy, and neurotrophic ulcer or refractory ulcers. These are what basically where it's probably the most useful, because nothing else works, then you have to do an amniotic membrane transplantation. So the neurotrophic keratitis is basically as a result of nerve damage, reduced corneal sensitivity, and reduced healing. Causes are multiple, but most common is herpetic keratitis, trauma, diabetes, and other neurosurgical procedures. So basically, it's a step ladder approach. First, we artificial tears, then tarsorrhaphy and other things fails, then probably we have to go to amniotic membrane, and we make use of its properties like neurotrophic factors, which promotes the growth and promote the surface healing and corneal regeneration. These are just so depending upon how you use it, there are three types which you can use, like inlay graft, onlay graft, and patch graft. For the sake of residents here, so inlay is where we use multiple layers, where we stroma down and the basement membrane up. So it will integrate with the surrounding tissue and give a substance to the cornea, and then the epithelium grows over it. Onlay is like a bandage contact lens. Here, the epithelial side is down and basement is up. So it is used especially in procedures like non-healing epithelial defects, and where you do not want to have semblifron or encaloblepharon preparation. Eventually, it will get disintegrated and it will be shed off. Quite often, when you have non-healing plus there is stromal tissue defect, you use a sandwich where you use multiple layers and then you put a onlay graft over it. So just a representative case, 57-year-old male, history of HSV keratitis, refractory to conventional treatment. So there are various ways you can do it. For dry, you can just put it over the cornea and put a bandage contact lens over it. For the wet amniotic membrane, you can either suture it, or you can use fibrin glue. In our settings, basically we Indian settings, we always try to cut down the cost. So this is what I usually do. Take out the amniotic membrane. It comes on a nitrocellulose filter paper. You peel it off, spread it onto the cornea, and then with the 10-0 running suture, you go just near to the limbus where the cornea is thickest, go circumferentially all around. Sorry, will just take a minute. And then you bury the knot and cut off the edges, excess edges, and put a bandage contact lens on it. Then you let it stay like this and continue with your systemic and oral antivirals, antibiotics, and so on. So postoperatively, usually these patients do well, and you get good success in majority of cases. So these are some other cases where these patients were sent for therapeutic PKP, but with intensive antimicrobial and amniotic membrane transplant, they usually end up healing well with good visual outcome and no need for keratoplasty. So advantage is easily available, relatively inexpensive, transparent or semi-transparent, how you use it, non-immunogenic, good substrate for epithelial growth, cosmetically accepted, and provides smooth surface to cover raw areas. And very important, there are no ethical issues like HOTA. So it is basically everybody can do it, who can do suturing should be able to do it. So these are some of the properties. I'll skip in interest of time. To conclude, it's a valuable adjunctive treatment in the management of various ocular surface disease, and main challenge is to incorporate in academic and private settings. The availability and the logistics and all these issues are there. So there is an urgent need to develop the infrastructure to address the unmet needs of the patients as well as of ophthalmologists. Thank you very much for your attention.
Very nice presentation, Dr. Pavan. You have highlighted all the uses of amniotic membrane in a very concise and good way. Any questions from the audience? Thank you.